So if we compare the overall etiology and the pathophysiology of both boys and girls, we will understand that delayed puberty is much more common in boys, but the likelihood of pathology is lower. So we need to be very careful in terms of not doing unnecessary workup in these scenarios because that can cause more confusion. So this was a 13-and-a-half-year-old boy with delayed puberty who was referred with a testicular volume of just 3 ml and pubic hair stage 1. So parents were concerned that there is delayed puberty. He was relatively short for the family with a normal weight. On investigations, he had undetectable LH and testosterone. Now, based upon this, the treating physician made a diagnosis of hypogonadotropic hypogonadism and advised a MRI head. Now, this was a very troublesome situation because parents were really concerned about not only the short term, but also in terms of the long-term future of the child and also whether there could be a pathological cause in that perspective or not. Now, if we can look at this case very carefully, we'll see that this is too early an age to evaluate for delayed puberty. He is probably going in more like a constitutional delay of puberty and growth, if at all anything. So this child should not have been worked up at all in this scenario. So I think this gives us an idea as to how so many cases where workup is not done, we are unnecessarily causing confusion in terms of evaluation. Contrary to that, we had the 16-year-old boy who presented with pubertal concern, who had an onset at 13 years. So puberty had started and then it stopped for 2-year period. At that point of time, when the child was seen by a physician, it was found that he had a testicular volume of 3 ml, which was soft. He had pubic hair development, which was a proof that there was a development to start off, and now the development has stopped. He was reasonably tall, and then he was labeled as constitutional delay of puberty and growth from that perspective. So this case scenario, in fact, if you look at it, there were everything which was going on, which was against the diagnosis of CDGP. This was a 16-year-old boy. Of course, there was the onset of puberty. The testes were there, and there was pubic hair development. The height was normal. So these are all against CDGP. So when we talk about that, we'll discuss about what are the pointers which go against CDGP. In this case, clearly developed and was found to have a brain tumor, which was causing these problems in that perspective. So this was a case in which we had missed the pathology. So in evaluation of puberty, which is a common scenario, 5% of all boys have delayed puberty. Physiological causes are common around 70% of cases. 30% have a pathology. What's important is that we do not do unnecessary workup in these 70% as was done in the first case, while we do not miss a pathology in the second case of 30%. This whole talk over the next 1 year, we'll discuss about the strategies about how to not do unnecessary workup while not missing on pathologies. All these resources are available in our website learning.growsociety.in, which offers a lot of resources as well as courses in pediatric endocrinology. We have our e-learning videos, so a lot of free stuff is also available over YouTube. There is option to look into our different courses, including fellowship courses in pediatric endocrinology and pediatric endocrinology for postgraduate courses as well. We frequently run grand rounds along with the PG lecture series and journal clubs to highlight these common scenarios. The books are available both online as well as the e-versions. Our app will help solve a lot of these problems. We'll try to see how it will help here. And today our focus is predominantly on delayed puberty in boys. The hypothalamic pituitary gonadal axis is the main controller of this axis. So we've got the GnRH, which is getting controlled via the stimulatory pathway, that is the KISS-KISS1 receptor, which in turn is regulated via the leptin. So when the body is at the right stage, it has got enough nutrition, the signal comes that, okay, this is the time now you can cross the toll bridge. So leptin is like a toll bridge. If leptin levels are low, you will not enter into puberty. But just because the leptin are high, you will also not enter into puberty. So you need to have all other things in place, and then leptin will be the final toll gate to decide whether you want to go ahead or not in that perspective. There are inhibitory pathways which include the neurokinin B and TAC3 receptor which regulate GnRH. So there is an active suppression of GnRH, which we discussed recently in our journal club, that this is actually established right when mini puberty is happening. So in the beginning, you have got the sudden surge in the levels of gonadotropin, and then the mini puberty surge sets in, which is inhibited. Now, this GnRH is then going to act on the FSH and LH. There is a common peptide regulating two important peptides, which then regulate the different parts of the testis. The FSH acts on the FSH receptor in the Sertoli cell to produce inhibin B and AMH, which are markers of Sertoli cell functions. These markers start to develop earlier. So they are early predictors in terms of testicular function. They may also be used as predictor of pubertal onset, which is there. LH acts on the LHCG receptor to act on the Leydig cell, and this is very, very important, and this produces testosterone. Now, we know that testosterone is very, very important between 8 to 12 weeks of gestation, because this is the time when there is the labioscrotal fusion. So if you have somebody who has testosterone deficiency, in the first 12 weeks of gestation, they will be atypical genitalia or hypospadia. Now, interestingly, HCG, which is coming from the placenta, will take care of this in the first 12 weeks. So you may have no pituitary, you may have no LH, or you may have a Kalaman syndrome, which is hypogonadotropic hypogonadism, yet the HCG will cover for the 12 weeks and avoid atypical genitalia in that regards. So individuals with hypogonadotropic hypogonadism present with micropenis and not hypospadia. So this is something which is very important, while individuals who have a problem in testosterone biosynthesis, testosterone activation or testosterone action will have both micropenis and hypospadias. Now, by the very nature of talk today, we'll focus predominantly on children who come to us with delayed puberty and not atypical genitalia. So we are mainly going to focus about those disorders from that perspective. Now, this testosterone is converted to dihydrotestosterone using the 5-alpha reductase, and then it acts via the androgen receptor. So the entire process is important. We'll talk about how steroidogenic defects in conversion of testo to DHT, and action of DHT will also result in delayed puberty in that regards. The Leydig cell also produces a very, very important peptide, which is insulin-like factor 3, which is primarily responsible for testicular descent in that regards. Now, GnRH is a primary regulator of reproduction, and that's why GnRH is extremely important from a species perspective for development. So the very important process which happens in terms of GnRH neuronal development and position is its migration. So GnRH neurons are actually developed via neural and ectodermal origin along the area of olfactory plecode. So they do not develop in the hypothalamus, they are developed in the olfactory plecode, and from there they have to migrate. And this migration process is very, very long. It involves a number of genetic factors. You can see multiple genes are involved. Once they come in that region, a very critical gene known as enosmin 1, which we know as Cal1 also, which is responsible for Kalaman syndrome, is there. And from there, multiple other factors are there. So what we can see that this migration of GnRH neuron from the olfactory plecode to hypothalamus is regulated by multiple genes. What does it mean? It basically means that it is extremely crucial for the body from a reproductive perspective. That is why you've got so many genes, which explains that many of these disorders will not have a classical Mendelian inheritance, and they may be oligogenic inheritance, in which many genes are required to be damaged before you go ahead to develop hypogonadism from that regards. Now, once they come in the brain, the GnRH neuron will go towards the hypothalamus and the olfactory neuron will go towards the olfactory bulb. So absent olfactory bulb along with anosmia is a very, very important sign which tells us that there is a problem in GnRH migration. So any boy who comes to you with delayed puberty, the first question you should ask is whether the smell sensation is normal or not, and you will get the idea here right away. Now, there are other neuronal migration defects which may happen along this pathway, which may result in other subtle features, like there could be a problem in terms of the symmetrical movements which are there in the body. There could be synkinesia, in which they have abnormal movement which is happening. There could be other features which are subtle features of hypogonadotropic hypogonadism and Kalaman syndrome, which we'll talk about subsequently. Now, this whole process is completed by 15 weeks, and that's why the role of HCG becomes important. Because by 15 weeks, you've got no GnRH, no LH, No testo. So where does the testo come from? It comes from the HCG, and that prevents the development of hypospadia in hypogonadotropic hypogonadism. Now, there are around 10,000 GNRH neurons which are migrating, and you don't need 100% of them. Even if you have 12 to 15%, they may be sufficient. And this forms the basis of a confusing picture of what we say constitutional delay of puberty and growth versus hypogonadotropic hypogonadism. Now, maybe a couple of decades ago, people said that, okay, there are two distinct conditions. One in which you do not have development at all and you will not develop, that is permanent HH. The other condition in which your development will happen later on and you will progress from there, which is a constitutional delay of puberty and growth. Now the data suggests that these are not two distinct conditions, but they are actually the spectrum of the same disorder. So the mildest form of hypogonadotropic hypogonadism and the severest form of CDGP may actually overlap. And there may be some genetic defects which are there, which are responsible for both CDGP as well as permanent HH, and that depends upon how they are expressing. What are the other factors which will decide about the phenotype? One simple way of understanding is that, okay, 12 to 25% is sufficient. If you have got 15-20%, maybe you will have later onset of puberty. And then what will happen is that you will progress from there. But if the numbers are very less, you will not enter into puberty. This also explains that many CDGP, whom we label CDGP, progress and then stop. Because maybe their neurons were very less, they had some initial development, then they stopped. So this CDGP may migrate to permanent HH. And on the other hand, we have seen individuals who had quote-unquote permanent HH. We gave them testosterone and after some time testicular volume increased. And that was suggested that, okay, they are going to progress. So don't consider CDGP and permanent HS as two watertight compartments. There may be some overlap which is there also in that regards. Now, gonadotropin levels, which we have discussed also in the case of girls, we know that both LH and FSH rise with puberty, but the rise of LH is much more, it's around 10 times as compared to the delta rise in the setting of FSH. So if you want to look at one sign of pubertal onset, LH will be a much better picture. However, if you are looking at a sign of gonadal failure, FSH becomes important because inhibin deficiency is more likely to happen earlier, and that's going to cause your high levels of FSH. So LH is a marker of hypogonadotropic hypogonadism and FSH is a marker of hypergonadotropic hypogonadism. So generally, with the newer chemiluminescence, we can easily identify between these conditions, and if required, we give GnRH analog, which are not very commonly given. If levels go above 5 milliunits per liter, it indicates that there is enough reserve and puberty is imminent from that regards. We should also understand that testosterone levels, and these are the most common tests we do once a child comes to us with delayed puberty. Check the testosterone level and then interpret it. We need to understand that testosterone depends upon the pubertal stage as well as the age. So at prepubertal stage, testosterone should be undetectable. People say 20 nanogram per ml as a marker, but usually you can say it will be undetectable. As the level increase, your level should increase. So whenever you're looking at testicular volume, try to see whether it is correlating with testosterone. If you have a large testis, but the testosterone levels are not that high, it would mean that there may be just Sertoli cells which have grown. Classical case will be hypothyroidism, in which you can have, and there is a correlation as levels go, maybe around typically 10 to 15, you start having levels pretty much into 150 adult sort of a range from that perspective. Remember, at lower level, the assays are not made to detect your testosterone at 20. They are made to detect testosterone as 100 to 200. So the enzyme assay based techniques or immunoassay based techniques are unreliable. If you want to really assess proper levels of testosterone in peripubertal boys, it should be a GCMS based assay in that regards. Testosterone is known to have fluctuations, so a pooled sample is required, and the levels are highest in the setting of early morning. Because your LH surges start happening at night, so testosterone starts peaking in the morning. So morning levels are ideally recommended in early puberty. If levels are low in early morning, it indicates that it is a less likely chance of puberty. But testosterone clearly is a late feature of delayed puberty, and there are other earlier, more sensitive markers like LH, GnRH stimulation test, and most importantly, inhibin B, which I'll be talking about, which will tell you much earlier whether the puberty is imminent or not. Now, in this context of these three organs, hypothalamus, pituitary, and gonad, and three hormones, GnRH, gonadotropins, and androgens, we can consider the possible causes of delayed puberty. It could be hypogonadotropic, in which, of course, the LH and FSH are low. The problem is in the hypothalamus or pituitary, or hypergonadotropic hypogonadism, in which the problem is predominantly in the gonadal level. You have high levels of LH and FSH. The elephant in the room, as far as the delayed puberty is concerned, is constitutional delay of puberty and growth. And it's the duty of the physician to not miss it and don't unnecessarily work up in that regards. Any systemic disorder will affect the hypothalamus through the leptin pathway. So leptin, kisspeptin will be low. Your GnRH will also be low. Other problems will include isolated defects, multiple pituitary hormone deficiency, any insult, trauma, surgery, radiation, infiltration can be there. The classical problems in hypogonadotropic hypogonadism may be testicular dysgenesis, Klinefelter syndrome, again is a very important cause, insult to the testis, receptor defect, steroidogenic defects, and all those scenarios will be there. Classically, complete deficiency of testosterone or testosterone action will cause atypical genitalia and not really delayed puberty. However, milder defects may present you with delayed puberty or maybe some small hypospadia which is missed in that regards. A major difference between hypogonadotropic and hypergonadotropic hypogonadism is the gynecomastia, which is substantially more in the setting of hypergonadotropic hypogonadism. All of you can go and have a look at our website where a lot of publications are available, our app which will help you in terms of evaluation and management, join our courses and look at free resources in our website.